Oral appliance therapy. What we're going to talk about is oral appliance therapy for our non-compliant CPAP users. Just for illustration purposes, I want to define what normal breathing is. When we look at this illustration here, normal breathing is a situation where the nasal passage is open and the tongue base is not occluding the airway. In an apneic breathing, we have a situation of one or two. You either have obstructions in the nasal passages and or the tongue base actually collapses into the airway. One apneic event is defined as when a person stops breathing for at least 10 seconds. Now, some of the solutions that can be implemented for treating patients with obstructive sleep apnea are dental solutions. There are three typical options that are presented. One's called a tongue retaining device. The second one is the mandibular repositioning appliance, which is the most common form of therapy. And the third is a combination where you actually can use an oral appliance as well as a CPAP. And we'll talk about that one towards the end. So to start off with, the tongue retaining device. Basically, the tongue retaining device is a bubble. The way it works is you actually squeeze the bubble and stick the tongue into it. When you release the bubble, there's a negative pressure that draws the tongue into the bubble. The idea is by bringing the tongue forward, you actually open up the oropharynx. The most important indicator for a tongue retained device would be individuals that don't have teeth, actually people that wear dentures. You need at least 6 healthy teeth in each arch to be able to use a mandibular repositioning appliance to bring the lower jaw forward. So what is mandibular repositioning appliance? The best way to define that is this maneuver. It's called a jaw thrust maneuver. It's a maneuver that's used to actually open up the airway. So think of mandibular repositioning appliance as a jaw thrust maneuver that keeps the airway open while the individual sleeps. That being said, there's just over 42 different FDA-approved appliances for achieving those same goals. And when you look at these devices, they may look a little different, but they all have the same goal. They have 2 parts to them, an upper and a lower. The idea here is to have the lower piggyback off the upper and bring the lower jaw forward. And it doesn't really matter which method of choice we use to achieve those goals. The only other reason for picking some of these devices would be more from a patient comfort standpoint and probably a clinician's preference. So how do they ultimately work? When we look at the way they work, what they do is they prevent the oropharyngeal tissue, this tongue base, for example, from collapsing and occluding. When we put an oral device in someone's mouth, it brings the lower jaw forward. While maintaining that position, it actually opens up the back of their throat, allowing air to passage. This is what's done with oral appliance therapy. CPAP will be the same argument, except it will actually blow the air past the obstruction. When you look at it from the perspective of what actually happens, the pictures on the left illustrate blue being the airway, red being the tongue, white being the lower jaw. This is looking at it from the back. This is looking at it from a bird's eye view. At the end of the day, when you bring the lower jaw forward, you get a lateral improvement in the airway. The airway actually improves from side to side as opposed to front to back. This is extremely important also in individuals that actually have tonsils, because if the tonsils on the sides of your throat, if the airway needs to open from side to side, those tonsillar tissues need to be removed for us to be able to optimize the airway. If you look at it from a volumetric standpoint, what you'll see on the illustration on the left, this is someone with their teeth together, roughly from the nasopharynx right up in here to about the oropharynx. The volume in this individual is 12.2 cc's. Just by bringing the lower jaw forward, you improve it to about 17.3. And if you look at the minimum area within the zone, it's roughly, 84.2. And the minimum area after bringing the lower jaw forward is approximately 198.6. So it gives you an idea that just by taking this lower jaw forward, not only do you improve the volume, but the minimum area within that airway also significantly improves. So how do they function? What actually happens is when you bring the lower jaw forward, it repositions the soft palate. This is why oral appliance therapy is extremely effective in snorers. Just by bringing the lower jaw forward, snoring stops because it tightens up the soft palate. The other 3 entities is the tongue. It repositions the tongue, the mandible, and the hyoid bone. Now what's interesting about the hyoid bone, a surgical procedure called hyoid suspension is where they bring the lower hyoid bone forward and they tie it to the larynx, does the same goal. By bringing the hyoid bone forward, it opens up the back airway. Well, with the oral appliance, you achieve the same goals just by wearing something in their mouth. Along with that, it stabilizes the tongue, the mandible, and the hyoid bone. Okay, extremely critical areas when it comes to obstructive airways. So dental devices. Extremely comfortable, easy to wear, they're small, easy to carry when you travel, especially for our traveling population. You've got a reversible, non-invasive procedure where surgery, once it's done, you can reverse it. It's quiet, it's accepted by bed partners, and has a significantly high compliance rate at about 18 months. What patients may experience when they wear this device is in the morning they may have a slight bite change, and this is purely from the fact that the jaw is held forward for 6 to 8 hours. All that is reversed by doing some morning exercises that are actually illustrated. The morning exercises are to actually get their bite back, and all it involves is biting on a little jig for about 2 to 3 minutes, and that reestablishes normal bite. You may get soreness in the jaw or the teeth. This is where adjusting the device is extremely important. Now, obstruction of the oral breathing with appliance in the mouth is very important. What we need to take in consideration is that even though we have an oral appliance to open up the airway, the individual still needs to breathe through their nose. The nasal passage has to be open. Because if the nasal passage is blocked, wearing an oral appliance and trying to breathe through the mouth is pretty much impractical. And excessive salivation, first 48 hours, your body's perception to that, it's food, you're going to drool a little bit more. After 48 hours, you return right back to normal. When you look at the practice parameters for oral appliance therapy, the suggestions are that for mild to moderate sleep apnea, it could be used as the first line of treatment. And for severe sleep apneics, CPAP needs to be tried. And if CPAP therapy has failed, then oral appliance may be an option. Side effects. Tooth, gum discomfort. Once again, adjusting the device normally takes care of that. Slight jaw soreness or tiredness in the morning, not uncommon, especially as they adjust the device to try and open up the airway. The bite change, it's temporary as long as you do the morning exercises. The pain, once again, in the jaw or the associated muscles, once again, these muscles are having to fire, the jaw is having to strain, hold the jaw forward, but all of this can be troubleshooted and addressed by adjusting the device itself. Teeth movement is not a major concern, but can be a concern when the device starts breaking down. 2 to 3 years from now, the device will start having cracks in it. It's only got a life expectancy of roughly 3 years. But if they continue to wear it, it will put aberrant forces causing teeth to move. Permanent bite change only occurs in individuals that don't follow through with the morning exercises. All right? We've done just over 800 appliances here at Fusion. I have only 5 individuals that have a permanent bite change. They take on this, they don't care. They don't care because they don't get this anymore from their bed partner. So it's a trade-off. It doesn't affect chewing, eating, and things of that sort. So it doesn't have any long-term consequences. The only consequences will be when you go to your dental practice for a cleaning, they look in your mouth like, whoa, what happened over here? Okay? Now, dual therapy. There's a time and place for it. Typically, it can be used in situations where the person cannot tolerate the CPAP pressure and they are severe apneic. Where the oral appliance, there's significant improvement in the apnea, but they still have some daytime sleepiness, or they still have some symptoms. In that situation, we can piggyback a CPAP, but the advantage of piggybacking CPAP and oral appliance is the CPAP pressure does not have to be at the diagnosed level. It typically gets dialed down. So if you look at this example right here, this gentleman gets diagnosed as having 46.8. He's a severe sleep apneic, tried CPAP, was not really compliant with it, went down the road of oral appliance. With the oral appliance, his apnea improved from 46.8 to roughly 21.5. Now, when you look at what is considered successful therapy, for a mild to moderate sleep apneic, if you get the apnea below 10, then the oral appliance is considered successful. And for severe, you just want a 50% or better reduction. That's the same criteria used in surgery. So if you looked at it from that perspective, the oral appliance theoretically would have been successful for him. However, he still had daytime symptoms. So with him, the second time around, we had the oral appliance and had him on a CPAP mask. And in the titration study, his events basically went to 0, maintaining his pressure at 9. His pre-pressure prior to oral appliance therapy was 14. Okay? Now you'll see a lot of this on the television, and you'll get a lot of patients asking about over-the-counters. And this is something I want you to be very well aware of. PO sleep is one. You'll have PO sleep that actually says that it is indicated for snorers. There's not that many that will actually be bold enough to say it's for apnea, but snoring is a good way to get them enticed. This, on the other hand, there's vital sleep. This one here actually, I think, makes a comment where it is for mild sleep apnea in the top line. Snore remedy is another one. Now, let's look at rip snore. We had a gentleman here at Fusion Sleep that actually wore rip snore for several years. Comes into the office, this is what the device looks like. You can see it's bulky, it's big, it's a ball and bite. This was his 3rd rip snore. Sadly to say that when he was wearing that device, he had a significant bite change. There were no instructions with these over-the-counter devices of what to do the next morning to reestablish normal bite. So the pictures on the left are his rip snore. The pictures on the right is a SUA device done here at Fusion. And you can see 2 things right off the bat. First, the amount of volume that the rip snore takes away from tongue, lip, and so forth in comparison to the sleep appliance made that's custom made. But when you put him in the lab and you test him, the images on the left, or the stats on the left, is 20.2 events he had with the rip snore in his mouth, and on the right is with the SUA down to 2.2. So just because they almost look the same, behave the same, have the same ideology behind it, One negative factor is the fact that the rib snore, being over the counter, takes a lot of volume away. So you still have to poke the tongue, poke the rib snore to try and open up the airway. Whereas custom-made devices are made to just be on the teeth, allowing as much room for your tongue so you can achieve better results. So what are the typical sequence of events? So basically the patient gets diagnosed of having obstructive sleep apnea. If they fall under the mild to moderate or the severe range, we have two choices. Mild to moderate, they could start off with oral appliance therapy, because it is indicated as first-line therapy, or CPAP. And the reason you may want to go CPAP is if they have comorbidities like hypertension, cardiovascular diseases, diabetes, you may want to start them off with CPAP. But if they're pretty much healthy and a mild to moderate, oral appliance would not be a bad first-line treatment. Now, if they go down the road of oral appliance therapy and everything goes well, we just put them on a 6-month follow-up. And if we do the oral appliance therapy and we don't get the results we so desire, we can do CPAP therapy, we can consider dual therapy, or maybe even make recommendations for surgical intervention. And with the CPAP therapy, the severe, we go straight to CPAP. We try CPAP as best as we can. If CPAP works well, they're put on a follow-up system. But if CPAP fails, whether it be compliance reasons or things of that sort, then we can go to oral appliance and give the oral appliance a route or an effort. Now here at Fusion, we've collected data from roughly 2008 to I think 2010, and we basically extrapolated mild, moderate, and severe cases just to give you what the success rate is. Using the same criteria that success is based on events being less than 10, these patients in the mild range have approximately 100% success rate with oral appliance therapy. All right? If you look at the moderate, we have roughly about a 93% success rate. And if we look at the severe, once again use the criteria of 50% or better reduction, it's roughly 93% success rate. But if you want to be critical about the severe and say, all right, let's use the same criteria as mild to moderate. The severe apneics, what percentage of them go below 10? It's roughly 68%. And to conclude, there's many studies done to look at the compliance. It does range, but what you'll find is the compliance over time is much better with oral appliances than you typically would find with CPAP therapy. All right, I'm open to any questions.